Thank you for introducing me. Ladies and gentlemen, good afternoon. Very welcome to this meeting, especially doctors from abroad. Because of shortage of time, let's get started. The topic is sequential segmental approach to congenital heart disease. So at the end of this lecture, we can understand how to logically approach to diagnosis and describe congenital malformation named sequential segmental analysis. In cardiac malformation, simple lesions such as septal defect or obstructive lesion is not a problem. But in complex malformation, heart position is an abnormal heart location, chambers are in unexpected position. So blood going to wrong way around. So the logical approach is needed. Basic concept is like this. Heart composed of 3 segments, atriums, ventricles, and arterial trunk, and 2 junctions, atrioventricular junction and ventriculo-arterial junction. So basic rules are to identify chamber, structure should be recognized by their own intrinsic anatomic features. Do not use the variable features to define another structure that is itself variable. For example, a chamber give rise to aorta is left ventricle. It's not correct. In TGA, RV give rise to aorta. So when we define a left ventricle, its own intrinsic anatomic feature should be defined. 3 facets of cardiac makeups are morphology, relationship, and connection. Remember, morphology, relationships, and connection. Step-by-step approach is following. First, identify segments, atrium, ventricle, arterial trunk. Assess the relationship, atrial situs, ventricular topology, and position of the aortic root relative to pulmonary trunks, and connection, atrioventricular and ventricular arterial connection pattern, and define visceral and atrial situs, and describe the associated anomalies. The first step, chamber of atrium, arterial chamber identification. Atrium has the component as following: venous component, vestibule, body, appendage, and pectinate muscles. And this is also vestibule, body, appendage, venous component. But among these components, the most constant anatomic features are appendage and extent of pectinate muscle. In this case, the appendage has a relatively broad base, and pectinate muscle extends all around the vestibule. This is the right atrium. Instead, in this case, finger-shaped narrow connection of atrial appendage and the pectinate muscle only confined to the appendage, and vestibule is smooth. This is morphologically left atrium. Again, broad-based atrial appendage and pectinate muscle extends all around the AV junction. Instead, pectinate muscle is confined to the appendage and the vestibule is smooth. Next, ventricle chamber identification. Ventricle has 3 components: inlet, apical trabecula, outlet, and the AV valve. So among these components, the most constant characteristic feature shows the apical trabecular pattern. In this chamber, the trabeculation is very coarse and disoriented. And in this chamber, very fine trabecular pattern, and AV valve apparatus, tension apparatus attached to septum, and this is clear septum. This is morphologically right ventricle, and this is morphologically left ventricle. And again, echocardiography or CT scan, we can find another characteristics, the offset attachment to AV valve. More apically attached valve is tricuspid valve. So this chamber is morphologically right ventricle. Again, we can notice the muscle bundle, septal to free wall. Usually, RV has this structure, moderate bend. So in this anatomy, for example, double in the ventricle, it's not easy to identify the internal structure. So the relative position, we can suspect the ventricular morphology. Small chamber, anterior part, and usually give rise to great artery. This chamber is morphological right ventricle. Instead, morphological right ventricle is rudimentary. The chamber is posterior inferior part of the ventricular mass and connected to crux cordis and no connection to our flow tract. This is left ventricle. The dominant ventricle is LV and RV. Okay. Okay. Atrial trunks. Atrial trunks has no intrinsic features. So we describe based on the branching pattern. Great artery give rise to systemic artery. This is aorta. And pulmonary branch, this is pulmonary trunk. And common arterial trunk has give rise to aorta, pulmonary artery, and also coronary artery. This is common trunk. And solitary arterial trunk is, in case of pulmonary atresia, there is only one outflow tract. And then relationship. Atrial relationship, RA is the right side. This is the usual side to soletus. RA is the left-sided. It's mirror images, sinus inversus. But in some complex heart disease, bilaterally RA auricle, bilaterally left atrial appendage. This is right isomerism, left isomerism. In other words, isomerism of right atrial appendage. This is isomerism of left atrial appendage by Dr. Anderson. And bodily arrangement, in this case, usual three-lobed short bronchus, two-lobed long bronchus left lung, atrial arrangement and abdominal organ like this. This is the inversus mirror image. Left side is the right lung morphology, right side left. It's just a mirror image. In these two cases, the visceral atrial cytosis is very concordant. As I said, in another case, three-lobed right lung, bilaterally right atrial appendage, sometimes associated asplenia. This is right isomerism bodily arrangement, and this is bilaterally long bronchus and two-lobed lungs, bilateral area appendage, and sometimes associated with polysplenia. This is the left isomerism bodily arrangement. But not all ways we can identify the atrial morphology by echocardiography, but sometimes we can suspect. In this case, spine and two great arteries are here. In normal, usual arrangement, the aorta is the left, IVs is the right. But in this case, two great vessels are juxtaposed. And slit-like inferior vena cava is a little bit anterior. We can suspect right isomerism. So CT scan of this patient shows there is a bronchial anomaly, but we still notify bilaterally short main bronchus. This is right isomerism. Other cases, two vessels are juxtaposed. Vein is slight posterior, and sagittal section shows that descending aorta and some venous drain. This is azygous vein. In this case, there is an IVC interruption with azygous continuation to the SVC. Left isomerism. The CT scan of this patient also shows the bilaterally long main bronchus. This is left isomer. Ventricular relationship, as you know, the primitive heart tube can bend to the right or left, usually right. This is right ventricle in the right side. This is the ventricular loop. If bended left, morphologic RV in the left. This is L-loop ventricular relationship, as in congenitally corrected TGA. So this chamber is an inlet part, outlet part, and septal surface. So hand topology means that thumb indicates the inlet, finger outlet, and palm faced septal surface. So we can only fit this figure right hand. This is right hand topology. That is D loop is the usual ventricular relationship. But in this case, AV valve, outflow tract, septal surface, only we can fit with left hand. So this is left hand topology, L loop, as in congenitally corrected TGA. So lastly, great arterial relationship. The position of the aortic root at the root level to the pulmonary artery, anterior, posterior, left and right. So normal relationship is aorta is right posterior part. This is site solitus. As you know, tetrals follow. There is some overriding of aorta, a little bit clockwise rotation of aorta. And in cases of DOLV, more overriding side by side or right anterior in various kinds of DOLV. In complete TJ, usually right anterior. Corrected TJ, usually left anterior. So this is inverse position. So we can describe great arterial relationship like this. And AV connection. So two types of AV connections, biventricular and univentricular. Biventricular means each atrium's irrespective right or left join to each ventricles, but in case two atriums join to one ventricle, this is univentricular AV connection by definition. Two atriums joined to one ventricle. Okay? So in some patients, the AV valve can overriding and straddling. Straddling means chorda tendine attached to the other side of chamber. This is straddling. But AV connection is usually well arranged, but in this case, AV connection is overrided, and also chorda tendine attached to the other ventricle is overriding and straddling. So if overriding, there is overriding AV connection is by definition so-called 50% rules. In this AV valve, more committed to this ventricle, this is biventricular connection. In this case, this AV connection is overrided, but major part is connected to this ventricle, so this is univentricular AV connection. And biventricular AV connection is following concordant, as you know, RALV, LALV. Discordant RALV, LALV. But in this case of atrial isomerism, so we cannot define concordant or discordant. This is a very ambiguous AV connection. But still, by two AV valve or common AV valve, still the connection is biventricular. Univentricular AV connections are, as I said, two atriums join into one ventricle, right? So double inlet ventricle and absent one AV valve. In this case, double inlet ventricle, two atriums join to morphological left ventricle, double inlet left ventricle. This is joined to RV, DIRV. This is one AV connection, absent right AV connection. this is absent left AV connection. Still, hemodynamically, RA, LA join to one ventricle, also in this case also single ventricle. As I showed, these AV connection double inlet left ventricle. This is more common double inlet left ventricle, visceral situs, usually solitus. VA connection is usually discordant. Dominant ventricular RV morphology is frequently associated with isomerism, and our flow track is from morphological RV, double or single outlet flow track. Typical case of double in the left ventricle, RA join to left ventricle, left AV valve, right AV valve, and small rudimentary chamber is left anterior and give rise to aorta. DILV, VSD, VA discordance. Okay, a typical type of DILV. Absent of right AV valve, for example, tricuspid atresia, there is no connection. This is the most common type. Sometimes there is some anatomical potential connection, but there's imperforate AV valve, still univentricular AV connection. The anatomy is, this is absent right AV connection. And absent left AV connection, mitral atresia, imperforate mitral valve, and other rare type can exist. This is the atresia of left AV valve. Mitral atresia, you know, there is no connection between left side atrium and the small slit-like chamber. There is no connection. So, lastly, VA connection. This is concordant to VA connection, LV aorta, RV pulmonary. This is discordant, LV to pulmonary, RV to aorta in complete TGA. This is double outlet, right ventricle and left ventricle. Two great vessels arise from the RV, so double outlet right ventricle. In this case, two great vessels from morphologically left ventricle. This is DILV, and this is common trunk, and it's a solitary trunk. These are the mode of VA connections. In DORV, so as in AV connection, there is overriding, more committed to LV pulmonary is, so this is discordant VA connection in DORV TJ type, usually. In this case, this is a transposition of great artery. This case, pulmonary artery more committed to the RV. So in this case, this is a double outlet right ventricle. Again, 50% rule, this is a double outlet right ventricle morphology. So there's a three segments of the heart: atrium, ventricle, and atrial trunks, and AV junction, VA junction. Firstly, morphologic identification of each chamber and relative relationship of the component in each chamber, and define AV connection and ventricular arterial connection, and describe visceral atrial situs and associated anomalies. This is the same step-by-step approach diagram. Thank you very much for your attention.